Immunotherapy is going to be the future of, mark my words, immunotherapy as of now will be the future of cancer treatment. So either DM immunology will boost like anything, or medical oncologists will learn immunology also. Okay. Immunotherapy. The 8th edition and 9th edition of Robbins, there are hallmarks of tumor, right? So self-sufficiency of growth signals, evasion of apoptosis, limitless replicative potential, to which one extra thing added was immunity and immune evasion. Immune evasion by cancer cells. This is the basis of immunotherapy. It's marvelous. How many of you have seen a sitcom, like a drama called Grey's Anatomy, like your Game of Thrones? There is one more thing called Grey's Anatomy. In that there is a character called forgot the name. It's a character, a girl, one of the doctors. She had melanoma. Isabel Stevens, right? Izzy had melanoma. They have tried immunotherapy for melanoma, and immunotherapy for melanoma is the first done thing, and you won't believe, it has literally cured melanoma in few instances. An early stage of melanoma, if it's detected, immunotherapy cured melanoma. If you can cure a cancer, that is like detecting Messi's step. That's why I said immunotherapy will be the future of cancer treatment. To know that, we should know a normal thing. I said, right, I'll come to this T cell receptor again. For any T cell receptor to function, or a T cell to function, you should need this antigen and an antigen presenting cell. There's one more thing called the second signal. This is also must. This is also must to for a immune response to occur. Okay. So we already saw something called immunological tolerance. Tolerance means my self-reacting lymphocytes are removed from my blood to prevent myself from, please carefully listen to this, to prevent from autoimmunity. Okay? To prevent from autoimmunity, tolerance is removal of self-reactive lymphocytes. One of the steps is called anergy. Otherwise, one of the steps of peripheral tolerance is called anergy. What happens in this anergy is B7 is nothing but B6, B7 is nothing but CD80, 86. What happens in this anergy is this CTLA4 goes and binds here. This PD1 goes and binds here. So the second signal is lost. When the second signal is lost, this T cell will not function. In other words, there will be a tolerance, and there will be no autoimmunity. Great. There will be no autoimmunity. Accepted? Is this clear? I'll just repeat once again, because the whole immunotherapy and cancer is based on this. Anergy is a method of peripheral tolerance, where CTLA4 and PD1 goes and binds, CTLA4 binds to CD28 and PD1 binds to CD80 or 86 and abolishes this signal too. So T cell will not function and there is autoimmunity. What my stupid tumor cell does is, it's so intelligent than us. It also follows the same step. My tumor cell also secretes these two and escapes from my immunity. Shit, great, right? The tumor cells escapes my immunity by producing these two things. God, it's intelligent. But we are humans, we evolve, we are much more intelligent than tumor cells. What do? We have anti-PD1 and anti-CTLA4. Great. We have anti-PD1 and anti-CTLA4, which will antagonize the effect of CTLA4 and PD1 and make the tumor cells visible for my immune system for destruction. Right? It's clear. I'll show the picture in Robbins next. And these two drugs are approved. Please note, this can be asked in pharmacology. Nivolumab, it's approved for melanoma and Hodgkin's, and Tata Memorial Mumbai is giving it for melanoma and also a few cases of lung carcinoma. So it's approved for melanoma, Hodgkin's, anti-PD1, and ipilimumab, it's an anti-CTLA4, and vaccine with CTLA4 is also in trial. All are future prospects. Okay, what it does is, this is what it does. This is what a tumor cell does. Leave this part, look at this part alone. This is what a tumor cell does. See, CD28, instead of that CTLA4 binds with B7. So signal 2 is lost or no co-stimulation. Or a PD1 binds. PD1 is nothing but CD8086. Again, no co-stimulation. See the beauty. Anti-CTLA4. Ipilimumab goes and binds with this. So the second signal comes. It kills my tumor cells. Wow. Anti-PD1. It binds. So the second signal comes. Kills my tumor cells. Great. Great, isn't it? So what I am doing in immunotherapy is, I am just priming my body's immune response to kill my tumor cells. Great? Awesome. I'll add one more thing, because this immunotherapy is already too much for us. I'll just add one more thing that's also given in Robbins. Adoptive immunotherapy. Please note this down. This term can also be asked in exams. Adoptive immunotherapy. It's called chimeric antigen receptors. Wait, I'll tell what it is. I have a tumor, okay, a lung carcinoma. I take out the cell. I see what antigen is present. So I take a antigen presenting cell from the patient. Chimera is doing something. Chimera is fusing something. So I give this antigen to the antigen presenting cell so that it presents the antigen. And internally I also add a domain which will activate other cells, activate the other lymphocytes and macrophages. So again, I took this antigen presenting cell from the patient. I have designed it in my lab like this. So I send this again to the patient. So what do I now have is an antigen presenting cell with an extracellular domain presenting this antigen from the tumor, and an intracellular domain which will activate other antigen presenting cell. So when I put this inside, it's going to proliferate n number of times and it will kill my tumor cells. This process is called adaptive immunity, adaptive immunotherapy. So adaptive immunotherapy and chimeric antigen receptors, these two words alone, if you remember, that's great. This is from Robbins. The chimeric antigen receptor has an extracellular domain which consists of an antibody that binds to the tumor antigens, and an intracellular domain that delivers the signal that activates cytotoxic T lymphocytes. So I design a lymphocyte and send it inside. Great, good. There are TNM classification has been changed to AJCC 8th edition, which is in effect from January 2017. The major changes. We all know N0, N1, N2, right? In between this, there's a thing called NITC, that is isolated tumor cells. If you see small tiny cluster of cells in a lymph node, 2 mm, up to 2 mm, I call it isolated tumor cells. Except, this is common, this can be an MCQ, the size can be an MCQ, first point. Except melanoma and Merkel, where I call it N1, this can also be an MCQ. Isolated tumor cells, not more than 2 mm, small clusters of tumor cells which are recognized by immunohistochemistry or H&E stains in a lymph node, is called isolated tumor cell, NITC. In melanoma and Merkel alone, it's called as N1 and not as ITC. These two are MCQs. Head and neck and penile carcinoma, they have introduced P16 immunohistochemistry as a surrogate marker. It's for HPV infection. If the patient has HPV infection, the patient will be positive for P16. Penile carcinoma, yeah, HPV related, and head and neck carcinoma, you know why it is HPV related. It's also been HPV related. So for reporting these two, this staining is must. That's one important change. Thyroid, they have changed the TNM staging. Thyroid before T4 was all extrathyroidal extension. Now they have made it into T3B if it involves only strap muscles. Other extrathyroidal is T4 again. If it involves only strap muscles, it is T3B now. Tumor of any size with gross extrathyroidal extension invading only strap muscles makes it T3B, and the age has been changed to 45 to 55. This is a very commonly repeated MCQ. The age has been changed now to 45 to 55. These two are very important changes for clinical practice as well as for MCQ, because most of the time you will be given a clinical scenario and asked what stage it is. Now T4 may change to T3B. Note it. And esophagus. Okay, I'm poor at diagrams, sorry. So if there is a tumor extending from here to here, where do I classify it? Under esophageal carcinoma or under stomach carcinoma? So for that they have said epicenter means the center of a tumor. Okay. If this big is the tumor, this one is called the epicenter. If this epicenter, if there's a tumor this big, okay, if this epicenter is within 2 cm of the JE junction of within 2 centimeter of JE junction, I call it, or I classify according to esophageal. Okay, same diagram. If this is a big tumor involving esophagus as well as stomach, and the epicenter is here, which is greater than 2 centimeter of the JE junction. If this is greater than 2 centimeter, I classify along as stomach carcinoma. This is important again. I said no, I will introduce you to few more terminologies. Omics. I am working on this. Omics. Write all these terminologies down one by one. Okay. First one. Quantifying RNA expressed across the entire genome is called transcriptome. Omics. Measuring the protein produced simultaneously is called proteome or proteomics. And knowing the cell's metabolites at the time of the tumor is called metabolomics. We already know seeing the whole exon is called exome or exome sequencing. Genome sequencing, genomics. All these can be asked. What is transcriptome? What is proteome? What is metabolome? You can ask. Transcriptome is, I am repeating again, quantifying all the RNA expressed in a cell population. Proteome is measuring the protein simultaneously. Metabolome is measuring the cell's metabolites simultaneously. The study of all these together is omics. It gives my gene, my RNA, my protein, my metabolites, everything together, so I can play with it. Literally I can play with it. Literally I can find where the fault is, and I can say or find a solution to treat the tumor. So omics is going to be the future of cancer, and omics has given rise to lots and lots of useful information which can be targeted therapy in futures. How many of you read books? Now, some books are awesome to read. When you read the book, it gives you lots of hope. For example, To Kill a Mockingbird. How many of you read it? A Kite Runner. Even Harry Potter, the Dumbledore, where he stands in the mountain and looks into the vast lanes of Ireland. It gives you hope. Robbin is one such medical book for me. See what he has said. Those of you who are still in medical school can now safely assume that expectations for rapid advancements in cancer diagnosis and therapy will be realized while you are still in practice. So get ready to treat cancer. Get ready to cure cancer. This is the last line where the neoplasia chapter ends, and that's the ray of hope which we live upon. Okay, you want me to go back again to all the changes in neoplasia? Rapidly I will go back to all changes in neoplasia. Neoplasia, tumorigenesis has been introduced. Go back through your notes. Tumorigenesis cell, Reed-Steinberg cell is a tumorigenesis cell. The concept of transcelomic spread has been removed in Robbins. So go for safety option of retrograde lymphatics for Krukenbergs. MicroRNA, there was already 2 types. One more thing called oncogenic microRNA has been introduced. MicroRNA 17 was the first discovered. MicroRNA related to RAS and MYC oncogene. RAS oncogene is related in lung cancer. MicroRNA which controls BCL2 is related with leukemia. RAS and P53, both the number has changed, 30 and 75. This can be asked. Have a look at it. Quiescence means temporary cell cycle arrest. That's a new term introduced. Oncometabolism is an entirely new concept. The enzymes involved in Krebs cycle, isocitrate and succinate dehydrogenase, the oncometabolated 2-hydroxyglutarate, which has an epigenetic modification and causes cancer. The tumors associated are cholangiocarcinomas, gliomas, acute myeloid leukemias, and sarcomas for IDH. Especially gliomas look for a need because it has been used in diagnostics by pathologists for quite some years. And SDH, it's renal cell carcinoma, and just immunotherapy and cancer is mind-blowing. This is normal T cell. It needs two signals for functioning. The second signal is where energy or tolerance is involved. So CTLA4 and PD1 binds to these, and so the second signal is lost, so self-reacting lymphocytes are eliminated. My beautiful brainy cancer cells also use the same mechanism, but I am smarter than cancer cells. I have anti-CTLA4, the drug is nivolumab, and anti-PD1, the drug is nivolumab, and anti-CTLA4, the drug is ipilimumab, which blocks this and shows to my body that immune cells is there is something abnormal, so you go and kill it. So that kills the immune cell. It's approved for treatment of melanoma and Hodgkin's, and melanoma it has almost given 100% cure rate in stage 1 and 2 of melanomas. And there's one more thing called adoptive immunotherapy, where I take out the T cell and I modify the T cell to produce antibody and to activate other T cells. That's called a chimeric antigen receptor, and I inject it again to the patient. It's individualized therapy. So it's chimeric antigen receptors and adoptive immunotherapy. If you remember these two words, it's well and good. AJCC 8th edition, ITC 2 mm or less, cluster of tumor cells, H&E or immunohistochemistry, it's called TITC, except for melanomas and Merkel's, where it is still called as N1. That's a MCQ point. Head and neck and pineal cancers, P63 is routine and HPV infection is associated. Medullary carcinoma of thyroid, papillary carcinoma, follicular carcinoma of thyroid, C, no anaplastic. That can also be asked as an MCQ. The T4 has been modified. T3B is extrathyroidal extension only to strap muscles, and the age has been changed from 45 to 55 years. Esophagus and stomach, where to put, where to classify, the epicenter 2 cm and 3 cm has a role. Omics, transcriptome, what is exome, what is genome, what is transcriptome, what is proteome, what is metabolome, you should know it. All these can be, transcriptome means 4 options. All these can be new options. Okay, and have a hope. Now I'll go to systemic pathology, the WHO classifications. WHO hematology has much more classifications than other things. First change, mastocytosis has been removed from myeloproliferative neoplasm. It's a major change. Mastocytosis is a separate entity now. It's not under myeloproliferative neoplasms. It's a separate entity. Write it down. Just point wise. No need to anything. Just point wise to memorize. Mastocytosis is a separate entity, not a myeloproliferative neoplasm. Just this. Just write this. That's enough. Okay. Other classification of mastocytosis remains the same. Chronic myeloid leukemia. There's a provisional response to TKI introduced. TKI is tyrosine kinase inhibitor. There's a provisional response to TKI which has been introduced in accelerated phase. Accelerated phase has that thrombocytopenia, thrombocytosis, leukocytosis, spleen, and other mutations. Along with that, tyrosine kinase inhibitor has been used as a provisional response criteria. Right? Note this. Blast crisis. What's the most common blast crisis? In CML. In CML, it is acute myeloid leukemia greater than acute lymphoid leukemia. It is said that in accelerated phase or even in chronic phase, if you see lymphoblast, morphologically if it looks like lymphoblast, that should be mentioned, because MCQ point of view, ALL blast crisis is very rapid and aggressive. Okay, it's very rapid and very aggressive. The question is, the most common blast crisis in CML is AML. The most aggressive blast crisis in CML is ALL. Okay, they can play with the words. The most common blast crisis is AML. The most aggressive is ALL. Okay, chronic neutrophilic leukemia. Just write this alone. CSF3 receptor, and this particular mutation is diagnostic of chronic neutrophilic leukemia. CSF3R mutation, yes or no? It's okay. CSF3R, it means 618th amino acid tyrosine diisocyazine. CSF3R receptor, just write below mastocytosis, right? CNL CSF3R receptor mutation, diagnostic. Polycythemia vera is great. Polycythemia vera, almost everything is changed. 2008, the hemoglobin was 18.5 in men and 16.5 in women. In 2016, it was 16.5 in men and 16 in women. Hematocrit was not there in the criteria in 2008. They have introduced hematocrit in the criteria in 2008. 16, 49 and 48%. Bone marrow biopsy was in minor criteria in 2008. Now it is in major criteria in 2016. This is very important. It's a big change. And in minor criteria, endogenous erythroid colony formation was there, which is removed now. This could be an all except question. Okay, why this change happened is because they thought that polycythemia vera is being underdiagnosed. I'm repeating it again. The changes, write point by point. The next, after CNL, the mastocytosis first, CML, CNL, polycythemia vera. First point, hemoglobin change greater than 16.5 in men and 16 in women. Hematocrit introduced, 49 in men, 48 in women. Bone marrow BM biopsy is a major criteria now. The fourth one, the endogenous colony forming unit has been removed from minor criteria. Okay, fourth, the next change, myelofibrosis. Myelofibrosis had 4 minor criteria before. Now they have added the leukocytosis. This has been added after polycythemia vera. 4 points, right? Myelofibrosis, leukocytosis, greater than 11,000 been added as a minor criteria, and this one, this is more important, CALR mutation has been added. Like CSF3R mutation for which disease? Good, chronic neutrophilic leukemia. CALR mutation for myelofibrosis has been added in the major criteria. These are the two changes. CALR is calreticulin. It is seen in JAK negative, MPL negative myeloproliferative neoplasm. This is important. Okay, CALR is calreticulin, and look for this in JIBMA exams. Why, I won't say. Acute myeloid leukemia, the next one after myelofibrosis, right? AML, the changes in AML. Provisional entity of BCR-ABL has been introduced. APL with mutated MP1, which is already a provisional entity, and AML with biallelic mutation, not single, biallelic mutation is a provisional entity. and AML with mutated Runx. Runx was translocated before. Now AML with mutated Runx is again a provisional entity. These are all memory based. Write everything down, take a snap and put it as your mobile wallpaper. You will never forget it because you will see your mobile 100 times a day. AML with BCR-ABL, AML with NPM1, AML with biallelic CEBPA, and AML with mutated Runx. Okay, there's one more thing in AML with FLT3 mutation. Two things you have to remember with this mutation. This was my thesis topic. Okay, it has a poor prognosis and it has a targeted therapy, sunitinib, which is used in renal cell carcinoma. Sunitinib, targeted therapy, and poor prognosis in FLT3 mutated. It's not still in classification. It has a prognostic value and the targeted therapy is sunitinib. These two are things with FLT3 mutated AML. ALL, again in BALL, same BCR-ABL has been added like in AML, and also one thing called IAMP21. This is also added. Again, it's memory based. I can't help it. These are the changes in BALL. Again, BCR-ABL and BALL with IAMP21. There's addition in T cell ALL also. Early T precursor lymphoblastic leukemia and NK cell lymphoblastic leukemia. Before it was NK cell leukemia, that is entirely different. Now NK cell lymphoblastic leukemia has been introduced. These two have been introduced as provisional entity in TALL. In TALL, early T cell precursor lymphoblastic and NK cell lymphoblastic, not NK cell leukemia, that's already known. NK cell lymphoblastic. Okay, that's in TALL. Myelodysplastic syndrome, this one major change. Before it was called as refractory anemia with excess blast or refractory thrombocytopenia. Now everything has been changed to the word MDS. There's no more refractory. It is MDS with single lineage, MDS with excess blast, MDS with isolated deletion. Okay, and there's a provisional entity, refractory cytopenia of childhood. Refractory cytopenia of childhood. This is a provisional entity in MDS. Okay, there's change in terminology and there's a provisional entity. Hairy cell leukemia, what's a genetic abnormality? It should be in your fingertips. BRAF. Other tumors with BRAF, that's a PGI question. That also you should know it. BRAF is seen in approximately 95% of the cases. There are conditions where BRAF mutation is not seen in hairy cell leukemia. So BRAF negative hairy cell leukemia, BRAF negative hairy cell leukemia has MAP kinase mutation. So BRAF negative hairy cell leukemia has MAP kinase mutation. Okay, this is an extra additional point. What is the IHC marker for hairy cell? Excellent. Annexin V. Cytochemistry. Cytochemistry marker is TRAP. Okay, fine. And note this down. B cell monoclonal lymphocytosis. This is a totally a new entity, and this is, you must know this. The provisional entities, if you don't know, it's fine. Other things, this you must know, because it is a precursor lesion to CLL. chronic lymphocytic leukemia. It's a precursor lesion. So CLL, the cutoff point is the absolute lymphocyte count should be greater than 5000. Here the lymphocyte count up to 5000. It should be monoclonal. That's why it's a tumor. IHC should be like of a CLL or a mantle. There are two things, low count and high count. And it's seen in 12% of the healthy individuals. Okay. Monoclonal B-cell lymphocytosis, it's a precursor lesion of CLL. The cutoff is the lymphocyte count should be up to 5000. The IHC feature should be of a CLL or a mantle. It's found in 12% of our normal individuals, and there are two types, low count and high count. Please look for this question in PGI, because it's a multiple choice questions can be easily selected based on these criteria. So please look for monoclonal B-cell lymphocytosis in PGI Chandigarh. That it is mostly expected. 5 points you have to remember. Myeloma. Myeloma is not WHO 2016. All these changes are 2014 changes, but they are not there in most of the guidebooks. So only I am putting forward them. MGUS is the most common thing, we know it. But MGUS has three types: non-IgM, IgM, and light chain MGUS. The definition is going to remain the same. There's no change in the definition. Okay? There's no change in the definition. But what's important is the prognosis rate. Non-IgM MGUS has 1% change to myeloma per year, whereas IgM MGUS has 1.5%. Light chain MGUS has 0.3%. Okay? Fine. I'll give you the PDF format of this, so don't worry about if you are not able to write all these things. Smoldering myeloma. Smoldering myeloma has also a change. Change is, before smoldering myeloma, it was clonal bone marrow plasma cell greater than 10%. That's all. Now there is a cap. It should be 10 to 60%. This is very important. I'll tell why. The cap should be 10 to 60%. Rest all remains the same. And here, risk of progression to myeloma is 10% per year. 1.53, but here it is 10% per year. It's for smoldering myeloma. Okay? The next one, solitary plasmacytoma. Now solitary plasmacytoma has two different things. The classical definition of solitary plasmacytoma is absence of bone marrow involvement. But just to confuse us, they have introduced solitary plasmacytoma with minimal bone marrow involvement. It means less than 10, like MGUS. Solitary plasmacytoma with minimal bone marrow involvement. Again, what is important is the progression rate. To myeloma, it will progress 10% in 3 years. But see, if when minimal bone marrow involvement, it has 60 and 20% if it's a bone and soft tissue. The progression rate is 60% for bone and 20% for soft tissue. The progression rate is exponentially high. Okay? We'll go to the next one. Yeah. I said these are all old ones. Ignore this. These are all old ones. I said right, the cap was 10 to 60%, and it's very important for smoldering myeloma, because if you see a bone marrow with plasma cell greater than 60%, even in the absence of Grab criteria, carefully listen to me. If you see plasma cell percentage greater than 60%, even in the absence of Grab criteria, you can call it a myeloma. Okay? These are called biomarkers of malignancy. This can be an easy question with all except. Involved to uninvolved serum light chain greater than 100. Again, only this I can call it a myeloma. Focal MRI lesions greater than 5 mm the size in the absence of all known conditions which can produce it. Okay, then only I can call it myeloma. Focal MRI lesions in the absence of all other conditions which can produce it, I can call it a myeloma, even in the absence of the Grab criteria or anything else. Okay, fine. That's why the cap of 10 to 60% came in smoldering myeloma, because of this. This is just a compilation of the progression rate which could be useful. Light chain 0.3, non-IgM 1, IgM 1.5, smoldering 10. All these are per year. From now it is per 3 years. Okay. Solitary plasmacytoma without 10%, with minimal but in soft tissue 20%, with minimal in bone it is 60%. Right? Good. Hodgkin's. Hodgkin's, there is not much of a change. One change which I have already told. What is that in Hodgkin's lymphoma? Great. PD-1. Anti-PD-1 is approved for treatment for Hodgkin's, and PD-1 is seen in Hodgkin's lymphoma. Only one thing, this is an old change only, but has not been mentioned in book. In Ann Arbor staging, we use E for extralymphatic and S for spleen, right? Similarly, we use the alphabet X if the lymph node or any mass is greater than 6 cm, or if it is involving greater than 1/3 of the mediastinum. Then I call it a bulky disease. Okay, and I call it a bulky disease, and I give a name called X. Fine. The other update we know, it's the PD-1. It's approved, the anti-PD-1. What's the drug? Nivolumab. What is anti-CTLA-4? Ipilimumab. Great. RBC. RBC disorders I am including because most of the guidebooks don't give the current scenario of diagnostics which is approved seen in lab. This is one thing which has been wrongly perceived for ages together. Definitive hematopoietic stem cell arises in, like 90% of you will say this is the answer, but the answer is intraembryonic aorta. See here, this is from Winthrop. It was believed to be extraembryonic. It was believed and not exactly true. But there are evidences that aorta, gonad, mesonephros, this region is the earliest onset of colony forming unit stem cell. Okay, aorta, gonad, mesonephros. Okay, aorta, gonad and mesonephros. And this is from Robbin's one. This is from Robbin's 9th, not even 10th, 9th edition. Definitive hematopoietic stem cells are seen in the mesoderm of aorta, gonad and mesonephros. If the word definitive is there, this is the answer. Okay? Great. RBC disorder. Now we all know hereditary spherocytosis, right? Hereditary spherocytosis occurs in mutation in spectrin, ankyrin, 4.2, band 3. Anything it can occur. The most common is ankyrin. So if a dye binds to band 3, the dye expression will be altered if any one of, consider this as a building. Okay, if spectrin is present, the building is going to fall. Anchoring is absent, building is going to fall. Same for 4.2 as well as band 3. So I am having a dye that's called eosin 5 manly amide. That's the dye which binds to band 3. So any of this mutation will affect the expression of the dye. So I can use this for diagnosis. Diagnosis in flow cytometry. Okay, this is the gold standard diagnosis. Most of the books don't mention this. This is the gold standard diagnosis. Okay, it binds to band 3. Band 3 and EMA, the short form approved is EMA, eosin 5 manly amide. Flow cytometry is the diagnostic test for hereditary spherocytosis. Eosin 5 manly amide. Okay. The next thing. This is also one wrongly conceived concept. Bite cell is formed due to, you must have been taught like this for years, removal of Heinz body by macrophages. Okay, just one logical questioning. RBC is like this. Okay, there is a Heinz body here. What it said is a macrophage will engulf the RBC, right? And it will bite it and remove it. Right? It will bite it and eat the Heinz body. So if it bites, what will happen? What is this? Break in cell membrane. Come on, dude. That's hallmark of irreversible cell injury, which means literally the cell death. If it bites, how can a cell circulate? That's nonsense, right? It's a wrong concept totally. How can a cell circulate once the plasma membrane has been destroyed? It will undergo necrosis. It will undergo cell death. It will not survive at all. What is the reason then? This was in 2009 and this is in 2012. I don't have the edition before this. That must also say the same concept. See here. The bite cells previously, I don't know how long before, they were considered as a consequence of splenic removal of Heinz bodies, but it is recognized that RBC forms a coagulum that is separated from the RBC membrane and often leaves an unstained portion of hemoglobin. That's the reason of bite cells, right? See, so the answer is it's the unstained part of the cell membrane and not removal of Heinz body by splenic macrophages. It is absolutely wrong. What's the screening test for G6PD? Know this. It's Butler's fluorescence spot test. This is how it will look. It's a test based on immunofluorescence. How immunofluorescence works, please go to my YouTube channel. There's a video on immunofluorescence IF for kidney. That's the same principle anywhere. So the cells which are bright have G6PD. The cells which are dull lack G6PD. This can be a picture based question also. PNH. Again, PNH also the diagnostic test. The diagnostic tests have gone way behind astified sucrose lysis, serum lysis test. Okay. Astified hemolysis test was used again. PNH, the screening is now in gel card test. What is PNH? PNH is loss of the GPA anchored protein, or in other words, CD55 and CD59 are absent. Okay, MIRL, this is CD55 and this is CD59. Okay, come on, listen carefully. Normal PNH, RBC with 55 and 59. I add antibody 55, antibody 59. What will happen? Agglutination, right? Agglutination result in heavy. So it will be top or bottom? It will be in the bottom, which means the patient is normal. See, bottom, bottom, control. CTL is control, bottom. It is negative, patient is normal. PNH, no CD5, no CD59. Antibodies I add. Will there be agglutination? Will there be agglutination? No agglutination, right? So it will stay in top. So this patient has PNH. It's actually the reverse. So you have to have a note on this. Okay? Fine? Great. The next one. The gold standard is FLAER. Expansion of FLAER, fluorescent aerolysin. If it's not there, if it's not there in the options, go for flow cytometry. If that also is not there in the options, go for gel card. If that also is not there in the options, go for acidified serum lysis. This must be, the Ames retired HOD would have said the question then. Flare, flow cytometry, gel card, and then acidified serum lysis. This is not there anywhere in India now. It's not done anywhere at all. Okay, so it's flare, flow cytometry, and gel card, then acidified serum lysis. This is the order for diagnosis of paroxysmal nocturnal hemoglobinuria. Okay. Men syndrome 1, 2A, 2B, familial. One more thing, MEN4. MEN4 has been introduced. It's a mutation in gene encoding for P27, which is again a tumor suppressor gene like P53. You have these three classical features of MEN1. In addition, you have genitourinary tumors. This can be asked because MEN4, it's not so new but has been introduced. MEN4 P27 mutation, that can also be an MCQ, or cyclin dependence kinase and nuclear factor 1 beta, CDKNB, that can also be a question, or which of the following are seen or which of the following are not seen can also be a question. Okay, MEN4. No, like MAB 1, 2, 3, this is also increasing. Like Men in Black, this is also increasing. Pheochromocytoma. When do you call a pheochromocytoma malignant? When you document metastasis. When you document metastasis, only you can call a pheochromocytoma as a malignant pheochromocytoma. This scoring system has been introduced called PASS score. Pheochromocytoma of adrenal gland scaled score. This score predicts malignancy. There are 11 points in this score. That's not needed, but pheochromocytoma adrenal gland scale score or PASS score predicts malignancy. This alone you have to know it. Okay, fine. Okay. Ewing sarcoma. IHC of choice. What is IHC for Ewing sarcoma? Huh? Yes or no? Correct or no? Old. The new one is FLI1 or FLI1 is the most sensitive and specific for Ewing sarcoma. DOG1, DOG1 greater than CD117. Again, it's more sensitive and specific for GIST. These are advances. Please don't go wrong on this. These are easy. You have to know. FLI1. No CD99, no MIG. If live on is not there in the option, go for this. Must be an old repeated question. There are risk factors, right? Modifiable, non-modifiable risk factor. One more risk factor for atherosclerosis or coronary artery disease. Okay. One more risk factor is clonal hematopoiesis. It is seen that when they do studies in old individuals, they have mutations in hematopoietic stem cells. That is common. Any person is going to have mutation. They propose that this mutation causes atherosclerosis. It may not be true, but the odds ratio is more for this, so they have proposed as a risk factor for atherosclerosis. Along with that body, type A personality, homocystinuria, add this also. Clonal hematopoiesis. Okay? This was there in 9th edition. The cardiac stem cells are seen in myocardium. The only advancement is there is some success that these stem cells can regenerate dead cells post myocardial infarction. Location of cardiac stem cells can be an MCQ. It's seen in the myocardium. Okay? Kidney. What is one advancement which I have told about renal cell tumors till now? Any guesses? If you want a hint, there's something related to TCA cycle. Awesome. Great. It is SDH. SDH is mutated in renal cell carcinoma and GIST. Okay, we'll go to kidney. Kidney has 2 to 3 changes. The first one is podocytopathies. This was my MD exam question. Podocytopathies, now they are reclassifying the diseases. Like now minimal change disease, what was a podocyte injury? That was the only podocyte injury. But now they are saying that even FSGS is a type of podocytopathy. The causes can be anti-podocyte antibodies, the nephrin, the podosin absence, drugs or toxins in case of minimal change disease. So the electron microscopic appearance is the same. Effacement of food process and vacuolization and retraction of cells from GBM. The next slide is going to be important. There are 4 patterns in podocytopathies. Please note this. Minimal change disease pattern, FSGS pattern, which I have already told. Another one is mesangial sclerosis pattern. Other one is collapse of GBM. This can be asked all except questions. All except questions, this can be asked. Okay. Minimal change, FSGS, diffuse mesangial sclerosis, or collapsing of basement membrane. These are the 4 patterns of podocytopathies. Please note this. This is not old, but this is new. This is not new, but is new to Robbins. Okay, new to an undergrad. Podocytopathies, there are 4 morphological patterns. Next one is C3 glomerulopathy. This is also not new to renal pathologists, but it's new to undergrads. The dense deposit disease, the MPGN type 2, this has been reclassified into C3 glomerulopathy. Good, right? So C3 glomerulopathy has dense deposit disease and C3 glomerulonephritis. The pathogenesis is the same. The C3 nephritic factor, factor H, factor I of the alternate complement, all these will have mutations. Okay. How do you diagnose? Immunofluorescence will have bright mesangial and glomerular capillary staining for C3 in both. And one peculiar thing about electron microscopy is it will have some called waxy deposits. The term waxy deposits is there. It's specific for C3 glomerulonephritis if it's waxy. Okay. Thumbprint sign in SLE is seen in thumbprint sign in electron microscopy is seen in lupus nephritis. That can also be an MCQ.